Welcome to the Buckingham Center for Facial Plastic Surgery video series. Tonight we're going to talk about skin cancer treatment. Now obviously, because I'm a facial plastic surgeon, this talk is going to be just about skin cancer on the face, and because to talk about each separate skin cancer location on the face would be a huge topic that would require hours of video time and probably bore you to death. So we're going to really talk about it in more of a general term about the process of treating skin cancer and why we do it that way. So there's three main types of skin cancer, and there's many other varieties of much more rare skin cancer that I won't go into what the treatments are for those individually. So the three main types are squamous cell skin cancer, basal cell skin cancer, and melanoma. Basal cell skin cancer is by far the most common type of skin cancer, but luckily it's also the most indolent, that is, the least aggressive and the least dangerous. Squamous cell skin cancer is the second most common and is intermediate in the way that it behaves between basal cell carcinoma and melanoma, melanoma being the rarest form of skin cancer but also the most aggressive as far as its ability to cause metastasis and eventual death if left untreated. The first two skin cancers tend to present as nodules, ulcers, scaly skin, things that you would normally think of as looking like that. A melanoma typically presents as a pigmented lesion, although there are varieties of melanoma that don't have any pigment in them, referred to as amelanotic melanomas. And so there are other more subtle signs that you look for in determining whether or not you might have a melanoma. So anytime you have an area of skin that is itching, bleeding, won't heal, has nodularity to it, is pigmented, is growing, has an irregular border, any of those things, I would strongly encourage you to visit your primary care doctor, or probably more importantly, a dermatologist, to look at those areas and determine what they might be, whether it be benign or malignant. We don't do skin checks in our practice as we're involved in the reconstruction of these skin cancers primarily, but on occasion we do find these in our patients. So once you determine that you might have something and you present to your doctor and a biopsy is performed and the diagnosis of skin cancer is made, that's where we typically come in. With a basal cell skin cancer or a squamous cell skin cancer on the face, it depends upon the location of that cancer as to whether we would recommend just having an excision done by us, and when we do that we just localize or put an injection of local anesthetic in the area, mark out what we think is the skin cancer and remove it, and then sew the wound closed. We then send the specimen off for a pathologist to check the edges and determine whether we got it all or not. If we didn't, then we need to go back into that area and take more out. So in certain areas of the face that's appropriate, forehead, cheeks, areas where you have lots of skin around the area to reconstruct things, and so if it comes back being positive, it's not that big a deal. More preferably, however, and as a essential feature of those basal cell and squamous cell skin cancers that show up in anatomic areas that are difficult, like the lips, ears, nose, eyelids, we team up with somebody called a Mohs surgeon. What a Mohs surgeon is a specialized dermatologist who's done extra training in a technique called Mohs surgery. That's spelled M-O-H-S, and is named after a gentleman, Frederick Mohs, who developed the technique back in the 60s. What the technique is basically microscopic removal of the skin cancer. It's appropriate for basal cell skin cancer, squamous cell skin cancer, and some of those other more rare varieties that I won't mention this evening. What the technique involves is, again under local anesthesia, scraping out of the tumor cells that will easily come out. So they use a curette first, because tumor cells are not adherent like normal cells are, to scrape out and better define what the gross margins of the tumor are. The Mohs surgeon will then remove a small rim of tissue around the cancer, will section it, provide stains so that they can look at it, and then they'll look at that tissue underneath the microscope while the patient is waiting in their office and literally map microscopically whether or not they have all the tumor removed. If there's an area that they map that the tumor is not all removed, they'll go back with that same patient in that day and take a little extra around that edge to make sure that they get all of the tumor removed. The significant advantage of Mohs surgery, and why we recommend it strongly for those areas of the face that are sensitive, like noses and eyelids, is because it is the most reliable method to remove all of the cancer cells while leaving the most normal tissue behind. We love Mohs surgery, and we really appreciate our Mohs colleagues because they are able to remove the cancer and leave the smallest hole for me to repair, which is where my practice comes in. We oftentimes team up with the Mohs surgeons so that everything is coordinated ahead of time. They go to the Mohs surgeon's office in the morning, the skin cancer is removed, and then depending on the defect, where it is and how big it is, they either come to our office or to the surgery center if some sedation is required, where we perform a reconstructive procedure to restore the face to its form as closely as possible prior to the removal of the skin cancer. Now, melanoma is a little different. Mohs surgery is not effective for melanoma because of the way that the specimen looks microscopically. You can't do a quick section or a frozen section, which is what you have to do for Mohs. You really need to do a permanent section. Now, there's some debate in that, and there are some Mohs surgeons who will do frozen sections on melanoma, but only about 5% of the Mohs surgeons in the country feel like this is an appropriate treatment, so most of them do not do that. I believe that permanent sections are a better way to control for removal of melanoma. So when melanoma is removed, it can be done by myself or a surgical oncologist or a Mohs surgeon, but if a Mohs surgeon does it or if I do it, then we will remove the cancer with a normal rim of tissue, and that normal rim size depends upon certain features to the cancer, and then we'll send that off to the pathologist while leaving the wound unclosed to look and see whether the edges are positive. That typically takes a day to turn around that specimen to determine whether or not the margins are free or not. And then once they are, we'll do a reconstruction. Now, in some locations on the face, it's not necessary to wait to do the reconstruction. Again, on the cheek or the forehead or the scalp, it's very reasonable to just remove the tumor and do the reconstruction, because if a margin comes back positive, it's relatively easy to go back and take a little extra tissue. Someplace like a nose, you really don't want to go in and do a reconstruction until you're certain that the margins are negative, so that you don't burn any bridges in being able to do an adequate reconstruction if a margin is positive. So that's the way you treat the primary tumor with melanoma. Now, oftentimes with melanoma, there's enough depth of invasion that we're worried about invasion into the lymph nodes. So in those cases, I team up with a surgical oncologist in town, and we do a technique, what's called a sentinel lymph node biopsy. Basically, that technique involves injecting a radioactive material into the skin where the melanoma is. That radioactive material drains to the most likely lymph nodes that could involve the cancer if it had spread, where we can go in and make small incisions and remove just those isolated lymph nodes that would be the first echelon, or the first lymph nodes that the cancer would have spread to had it spread, where those lymph nodes can then be sent off to a pathologist, again sectioned, analyzed to see if there's any tumor in the lymph nodes. And if there is tumor, then typically you have to go back and remove the rest of the lymph nodes to ensure that the adequate tumor has been removed. Again, I team up with a surgical oncologist in that case, where we both do the sentinel lymph node biopsy as a team. He's primarily or she's primarily involved in removing the tumor, and I'm primarily involved with the reconstructive effort. So I hope that's been a good overview about the 3 most common skin cancers, what to look for, who to see if you think you might have one, and how you might go about removing and reconstructing the area. Again, there's much more specifics involved in this that would have to be gone over at the time of a consultation regarding each particular space.